I'm kind of a hater, I'll tell you.
I'm really sad that the study's negative.
We're here to talk about the NHS-Galleri Trial. This was a clinical trial performed in England, and the purpose of which was to use a novel blood-based test to determine whether or not cancer could be caught early. The premise being that tumors will shed DNA into the bloodstream and be detectable.
The current version of multi-cancer early detection tests really has not proven what actually matters. The concern is that these tests will provide us a false reassurance.
The best early detection or breast screening test that we have is the test that we will do. Having options is going to be really important for our patients.
Those Super Bowl ads are really expensive. I read this year was like $8 million for 30 seconds.
Any money you're spending on marketing in the Super Bowl, for example, not cheap, spend it on making the test better, because absolutely it is the future. I don't disagree with that at all.
We have to be optimistic that this technology of ctDNA is going to make a difference.
Oh, information is power. Did you watch the Super Bowl? Did you see the commercial asking if early cancer detection is right for you? We're here to discuss it. I'm here with Dr. Shruti Patel and Dr. Shalom Beg. We're here to discuss multi-cancer early detection through the NHS study that examined this exact approach using cell-free DNA. Circulating tumor DNA has been really the explosive technology in the last 5 to 10 years. It's been used for people who already have cancer, but now it's being used to determine whether or not it's a new screening test definitive. So let's get into this. I'm going to introduce the NHS-Galleri Trial that's recently made a lot of headlines, New York Times, and really around the world. It is the first double-blind cancer screening randomized controlled trial. It was intended to detect late-stage cancer incidents earlier than it otherwise would have been through normal symptom detection or through early screening tests, which are limited based on the number of cancers that they studied. And we'll get into that. Interestingly, the primary outcome was not cancer mortality. This was a study that was performed by the National Health Service in England. They recruited more than 140,000 people between the age of 50 and 77 and followed for 3 years, getting yearly blood tests once a year apart for a total of 3 times. In these 140,000 patients were not people who had symptoms, but rather were followed. They had cell-free DNA detected, and it was intended to determine whether or not they could reduce the number of stage 3 and stage 4 cancers found. So we're going to get into this. There were a pre-specified group of 12 cancer types that we'll also get into, many of which were GI cancers and other cancers, some of which have current screening test modalities worldwide and some of which do not. And so I want to hear the perspective of my colleagues. Briefly, the study has been hailed as something that is, quote, negative. The number of stage 4 cases was lower than thought, but stage 3 was higher. And they also looked at stage 1 and stage 2. And we're going to get into this in our discussion. I want to hear my colleagues think about this. Negative or positive? Let's get into it.
I'm kind of a hater, I'll tell you.
I'm really sad.
Yeah, go for it.
I'm really sad that the study's negative, Shruti. Go for it. What do you think?
I gotta say, okay, it's not that I don't believe in early detection, right? Absolutely. I do think that that's how we're going to help cure cancer over the course of all of our lifetimes is early detection. But the current version of multi-cancer early detection tests really has not proven what actually matters. Set aside the fact that this randomized trial, huge randomized trial, didn't meet its primary endpoint. We also should eventually talk about whether that endpoint was even the right endpoint for the study. So first of all, to me, it wasn't even the right endpoint. And then they didn't even meet that right endpoint. And so, when you screen a large number of low-risk people, even specific tests are going to create false positives, high anxiety, unnecessary workups. It's also going to give people peace of mind that may not actually be there, because really what we want in an early detection test is to detect early cancers, which we know shed less circulating tumor DNA than the later stage cancers. And so I just think before we hail this as the future of screening and hims and hers, goes off and, gives this to all of their patients on their subscription plan, we just need stronger evidence. And I think that we should be thinking about how to deploy this in higher risk populations. Right. We know that there's a lot of risk factors for cancer. How do we kind of target these tests to those patients maybe we would get a positive kind of trial.
Look, at least one of
why are you so
us,
sad?
at least one of us is eligible for USPSTF screening modalities, and I guarantee you that those people have not gotten their screening tests. The best early detection or breast screening test that we have is the test that we will do. Nobody likes to take their prep and get the colonoscopies. Nobody likes to go in for their mammograms. Nobody likes to get their pap smears. The best test that we have is the test that people are going to do. And we know that a blood test, which can potentially detect malignancies early, has the ability to really increase the denominator of people who are going in to get evaluated for cancer screenings, for them to be identified. And the hope there has always been, how can we go from a world where we're detecting a high proportion of patients who are stage 4, meaning the cancer has spread beyond the organ that it began, and start identifying them at an early stage? So the specific study that we're talking about right now, the Galleri clinical trial, which was done in England with the NHS over there, looked at a multi-cancer early detection study, a multi-cancer early detection trial for average risk patients. So was the technology flawed? Was, like you guys are mentioning, the study flawed, or are we just barking up the wrong tree? Now, before you say that that we're not going to go anywhere with this, there are different technologies that are available. I think this was the wrong trial for the wrong patient population, and this is only the beginning of this entire field, and there's a lot more work for us to do.
Okay,
Let's go through go ahead, Shruti.
No, sorry. I completely agree. I think it's the wrong technology. I think that I think that there's a lot, and I think the technology that is going to make this better, not the one that's going to solve all of our problems, but the ones that are going to make this better exist. I just don't think it's the one that's being operationalized right in this trial with the Galleri. But I also think that your point is exactly, you're saying, like, getting this blood test is so much better than getting a colonoscopy. Completely agree. But you know what a colonoscopy does? It looks for polyps. It's trying to get you away from even getting your stage 1 colon cancer or your in situ, your stage 0 colon cancer. What is the likelihood that these tests are going to be able to not only get polyps, but even a stage 1 disease, when we know what we know about how early stage cancers shed? And so, yeah, I would love if there was a blood test, if all of the cancers shed and then there was a blood test that we could do. And if that's where, of course, I want that to be where we land. But I just feel like we are so far from it. And I think that patients and people, you hear about a blood test that can detect cancer, and of course, you're going to spend $1,000. Honestly, I would spend $1,000 if there was a blood test that told me I'd spend $1,000 every year for my entire family, if I actually thought that it was going to help. And you could imagine, cancer is so scary to people, right? Even though more people die from heart disease, I would say cancer gives people, in the United States, I would say cancer gives people a bigger visceral reaction. And that's why I believe that these things are really marketable to patients, direct to patient marketing. And I think that's why it's so important to tease out the details of studies like this, because otherwise you're treating anxiety, you're not treating true risk.
Yeah, let's put it in the basket of whole body MRI and some of the things that are, they're popping up on Instagram, the commercials that we're seeing online, the Super Bowl or otherwise. And so it brings to mind lead time bias. So it's kind of like this, so what? If something is detected, and with the GRAIL study, they're claiming 99.5% specificity. So in other words, very minimal false positivity. So if you take that out of the equation, something is detected, there's something there, then you have to go look for it, then further tests. So you may get invasive tests, you may get biopsies, otherwise it wouldn't be performed. But the question is, and the authors of the study, when they designed it, it's interesting. If you go back, Journal of the National Cancer Institute, last August of 2025, they wrote basically an editorial commenting on the design. And I think it was in the middle of things, reaction to the kind of the maelstrom that they're anticipating, including from what we're discussing right now. They anticipated the controversy that the final results will or are generating. And they've said, at least in the press releases from GRAIL, that there are results forthcoming to be presented at the ASCO annual meeting in June. So we're going to dive into that for sure more in June when those results come out.
So before the comment section gets on us, we only have a press release. We only know that this trial hasn't met the endpoint. We're waiting on the secondary analysis. We all
Of
know
course.
that. Don't attack us. But okay, so here's the thing. Maybe the trial could have only identified people with a higher risk. We've seen other studies with this assay that looked at symptomatic patients that has a different performance in that environment. And when you look at the entire ctDNA field, it's sort of gravitating into three buckets. We all understand the concept that cancer cells are shedding circulating tumor DNA into the bloodstream, and we know that via blood test we can identify the cancer tumor circulating tumor DNA and normal DNA and separate them out. But what we're really analyzing,
Sometimes.
we can do it pretty well, but there are different ways for us to do it. One is we can check the methylation markers, right? So the Galleri trial was
Yes.
looking at a methylation marker, which is like a cap that goes onto the DNA to decide if that DNA should be expressed or not. And that expression can tell you is it cancer or not. And they can look at the signature and say, hey, this looks like a breast cancer or a colon cancer. That's really cool technology. The other aspect that we have is there could just be ctDNA that are looking at DNA fragments. And the third are really looking at specific mutations that are present in some cancers or the other. The fragmentome, the methylation marker. This is, I agree. I think they went for the wrong endpoint. I think they set the field back by doing the study that they did. But I continue to be optimistic. We have to be optimistic that this technology of ctDNA is going to make a difference so that we can start identifying people with cancer. And if we can have a lead time bias with people who have cancer and find them when they're stage 1 and they're potentially curable, isn't that the goal?
I love your optimism, but you know what I'm going to say, and I'm going to clap as I said, because I've said it at the ASCO podium, not all cells shed DNA, not all cancer cells shed DNA, not all tumor types shed DNA. Let's walk through the 12, okay? Because I think I want to do this because, I mean, something near to our minds that we're familiar with, many GI cancers, basically from here to all the way to the end, but also some familiar characters in terms of solid tumor types that don't have routine testing, right? So in those cases, it won't be complementary. So let's just go one. I think it's kind of more or less alphabetical. Anal canal, right? So, you know, anal cancer, no routine testing, right? Bladder, okay, but colorectal, right? We have colonoscopies, we have the other stool testing, right? Esophagus, right? Aside from Barrett esophagus, we're not routinely scoping in there. Head and neck, right? Now I'm getting to the point where I'm saying I'm only halfway through the list. A lot of diversity. Liver, bile duct.
Are these cancers
Right,
that
so
do not shed? Is that the list that you're describing?
No, these 12 cancer types are the ones that were included in the NHS-Galleri trial. So they're the ones that they were looking for, and so the ones they were aiming to detect. So the people that were 3 clinically important groups of cancers, I'm just reading for focusing first in a pre-specified group of 12 cancer types that together represent approximately 2/3 of cancer deaths in England and the United States. So it's applicable to both, but they're looking as a secondary objective, reduction of stage 4 cancer. But these are the cancers they were really focusing on. In addition to those, lung. So you have low dose CT scanning for smokers now in the US. I'm not sure about Great Britain. Lymphoma, myeloma / plasma cell neoplasm, ovarian cancer that we know a lot of detection tests are being evaluated, but that's not yet ready for prime time. Pancreas, we know we're desperate for that, right? And stomach. So that's a lot of variety, many of which are GI cancers. But I guess my ultimate point of those is, other than colorectal, there isn't a sure bet routine. We're going to look for this. And then mammogram and breast, because breast was listed on there as well. But really, so many of these cancers don't have tests that would even complement what our findings are on the ctDNA test, the cell-free DNA.
Yeah, but just going back, okay, I completely agree. Again, I completely agree that there are not screening tests for a lot of those tests. And so once we have really great circulating like multi-cancer early detection tests that are much better than the ones we have right now, and there is proof that they are better based on it's really interesting. False positives actually stress me out. I know there's a lot of talk about unnecessary testing and all of that, and I agree that it's not great for the medical system and all of that. But frankly, if I was a patient and I was able to find that I had cancer, or I got a positive test and then I found out I didn't have cancer, I would be happy that I just didn't have cancer, or I would be happy that it was caught. And so I wouldn't really care about the false positives. To me, it's the fact that there are many cancer cells. It's not just all tumor types. Within the same kind of tumor type, there are some tumors, 2 identical types of patients. One will shed, one will not shed. And so for for me, the concern is that like these tests will provide us a false reassurance. That is actually more worrisome to me than the false positives. And so we already worry about people ignoring symptoms and things like that. I have literally seen patients who have ignored symptoms because they were like, "Oh, I got a multi-cancer detection test 2 months ago and it was negative. I couldn't have cancer." And so I feel like if we're going to be selling a product to the masses and we are not going to like need a prescription to get that test or anything, then it has to be a really good test.
If I have a patient,
That's my feeling.
if I have a patient who is I think we know that this test does not perform very well as a multi-cancer early detection for people with average risk. If I have somebody who comes to me and says, I have an increased risk of cancer, I have 3, 4 first-degree relatives who have different cancers and there's no specific cluster, and they ask me if they should spend the amount of money and do one of these commercial tests that are currently available, I don't think I'm going to talk them out of it. I'll ask them to go ahead and do that. Do you think there's reason for that individual who's affording otherwise to not take this test?
No, I don't. Because I completely agree with you that there is like, again, I'm actually like in general probably never going to talk somebody out of taking the test, in that I don't think it's going to viscerally harm them in a way that I think there are other things that people do that actually harm them. And again, I actually think that had they done this, because I don't think it's a very good test, but I think people who are at high risk of cancer are that high risk for cancer that even a not good, not the best test in the world would still help some of the people. And I think I wish they had designed this study to be in higher risk individuals for that exact reason. So I completely agree with you, actually. Even though I seem like a hater, I'm not quite 100% a hater. Where I think that there's absolutely a group of people that I would recommend this in. And, maybe they have like a VUS, but they have so much history in their family, but the genetic counselor is like, you don't qualify for Q6 month MRI or whatever. There's absolutely a world, but I am worried that this is being marketed to the healthy, anxious, rich, specifically, and I feel like without taking any of those risk factors, whether it's like ulcerative like if I had a 22-year-old who had ulcerative colitis and they didn't want to get colonoscopies, I'd be like, at least please get this. There's definitely a world in which there's value, but I just want the test to be better. Like, to me, okay, this is my really important take. Sorry, last thing is that any money you're spending on marketing in the Super Bowl, for example, not cheap, spend it on making the test better, because absolutely it is the future. I don't disagree with that at all, but I don't think it's the future for all people currently.
Those Super Bowl ads are really expensive. I read this year was like $8 million for 30 seconds. So $8 million well invested in improving the specificity and sensitivity and utility of it. So I think it comes back to, right, any test that we have in cancer, or just any test in the medical field, what are you going to do with the results? I think I'm a firm believer of knowing what you're going to do with the result. If it shows this, then here's how I'm going to do it, either as a physician prescribing it, or ideally as a patient, we're helping to educate our patients or anyone getting those tests to know. And so I think, bringing up that point, Shruti, to follow up on that, is I don't see it, at least from what Grail themselves described in that press release, they didn't see it as a replacement. For example, colorectal cancer as a replacement. Like, I don't feel like doing a colonoscopy. I don't want to drink that stuff that makes you poop out and it's very gross, but rather complementary. So I think what they said for breast, colorectal, cervical, and high-risk lung cancer, all of which have routine screening tests of various varieties, right? For cervical, you have the PAP, colorectal, of course, colonoscopy, mammogram for breast, high-risk lung cancer, we talked about low-dose CT screening. Annual screening with the test plus standard of care screening, they said, result in a 4-fold improvement in overall cancer detection rate. And so at that point, I think what they're saying is they're actually pointing out some false negatives that might arise from any of those screening tests, but saying, I saw it as the word complementary came to mind.
Yeah, I guess I'm like, I fully believe that that's in their asterisks. Oh God, I just seem like such a hater, but I fully believe that that's in their asterisks. But human nature is human nature, right? If someone's like, I really don't want to get a colonoscopy and I got a clear bill of health on this blood test, like whether the asterisk is there or not, if you don't want to get it, you're not going to get it. We already know that because a lot of people don't get colonoscopies. And so I hear you. I agree that it will be complementary, but I worry about the the people that are going to take that as like, okay, well, now I don't need to get my colonoscopy and I don't want to get it anyways, and I don't have the ability to take off work for a day or 2 days while I'm pooping my, it's anyways.
Well, let's take on this idea that, I'm wondering if it's going to be a shifting target. Isn't exactly right. I'm wondering if there was a preemptive strike, the editorial that the authors wrote in JNCI in August to say, hey, we chose this for a reason. We know that overall mortality is not the primary endpoint. I'm wondering if, based on the initial rollout, that they will shift and say, now we're going to follow those people we did identify with cancer and see mortality and see if our test made a difference. It'd be interesting to do that in design. But I wanted to point out also that they had reported that the stage 4 was lower, but the stage 3 was higher. And I think there can be a supposition where I think in the lay press and probably elsewhere on the professional stages as well, people might suppose that the stage 3s increased because they would have been stage 4s if not detected earlier using this yearly test. And what was interesting is they said there was a substantial reduction. I'm reading now a quote from the press release. Substantial reduction in the number of cancers detected clinically through emergency presentation, which are associated with significantly higher mortality and healthcare costs. So it's not just the financial toxicity of it, but what they're pointing out is, I think I'm reading between the lines of what they're trying to say is that stage 4 would be clinically presentable, and that's how it will be diagnosed in many of these people. But yet we caught it by a test when people were not symptomatic at stage 3. Which does make logical sense for some cancers, maybe not all, and not all cases, but I think that's why I really want to see the data.
That's where the manuscript really is going to be important. We'll see what the presentation is, what the manuscript is. And there's a whole other world of early detection blood tests that are disease specific, where you have assays that have been optimized for, you mentioned those already, they've been optimized for colorectal cancer, optimized for lung cancer. Let's not throw away the baby with the bathwater in this situation and assume that one study is going to define what the entire field is where the entire field is headed. Those studies have also faced some challenges in terms of their sensitivity specificities, but what they are focused on are the existing standard of care and what the sensitivity and specificity of those. For example, in the colon cancer early detection studies, they're comparing it with the sensitivity and specificity of stool tests to detect similar markers. Mm-hmm. And again, I would start off with saying that in this situation, having options is going to be really important for our patients. The best early detection test, the best screening test is the one that people will get.
Absolutely. No, I mean, you're totally right. Right. If someone's going to get a blood test, like someone's like, this is the only screening test I'm going to get. Of course, that's the best one. But I also want to point out that an interesting thing that I also think will come up is how frequently these blood tests need to be done, which is like a whole, we could probably talk about it for another 25 minutes, is once a year even often enough for some of the cancers, like, they grow fairly quickly. And again, is that how much time should someone feel like, okay, I'm good after you get a test like this? I think that's also important. So I don't know. I think that obviously there's a lot of questions. To be clear, I don't want to be a hater. I want to be obsessed with early detection blood tests, and I want there to be an amazing assay that helps us detect cancer earlier. But I just don't want people to get misled. But exactly.
Yeah, for now we have a test that is just a shade under, or maybe a few dollars under $1,000. Out of pocket pay. You're right. Not everyone will afford it. Not everyone will want it. But people of means who really want it, who can do it, are probably going to get it. I think even after these results, and they're going to say, for exactly the reasons we've been describing over the last 20 plus minutes, is that it's available. I want it. I want to know. Information is power. And so let the buyer beware. And then maybe we'll see more data and the manuscript, we hope, this summer, hopefully at the ASCO annual meeting or other forums in the coming year. And we're here to dissect it and take it apart. Any final thoughts, either one of you?
I mean, my final thought is I I understand that this is something that is like very needed. I know that patients really want it, and I even hesitate to have this take because I know that, you know, it is knowledge is power, autonomy obviously exists. But I think it's really, really important in this world where, you know, everything is on information. There's so much misinformation in social media. I think it's really important for people to know exactly what a test can and cannot tell them. And to be clear, no test is perfect, right? So, like, someone might argue, well, colonoscopies have their risks. Yeah, they're really low, but it's still a procedure, of course, and this is a blood test. So, like, you know, there's arguments to be made all around, but I think it's extremely important with the amount of marketing and money that's going into this versus nobody's trying to market colonoscopies. I think it's really important to be really clear about what it can and cannot tell people.
Yeah, hindsight is 2020. I don't want to hate on the investigators and the sponsor of this study. I do wish that they had a different endpoint. So, you know, we could have invested what we've learned from tens of thousands of patients. I forgot how large the study is, and at least have it had a more answer that was giving us clearer direction. But I'm continue to be very optimistic on the field of using ctDNA markers for early cancer detection.
Yeah, no, applause to the investigators, over 140,000 participants.
It's a lot of patients.
I think there is a lot to be dissected. I have no doubt there will be subset analyses upon subset analyses upon subset analyses. The appendix to the main paper, whatever large high impact journal will make it in, inevitably will probably be large, and we'll have to go through that very carefully to find some of those potential signals. So I think this is really a good launch of the discussion. I think we're going to continue this in the future because this is only going to be the first salvo, I think, and in all these debates about what is the endpoint, what makes a difference, what tests are on the horizon that people who are listening to us are going to want to investigate and ask, just like the Super Bowl ads ask your doctor if this test is right for you. Well, thanks everybody for listening. I hope you learned something and listen to us and subscribe to our channel.
Cool. Are we good?
Yeah.
Okay. Yeah. I have one request. Emil, can you introduce the study again in like 60 seconds? Or do you think that what you did is how you could do it?
Yeah. Like from the very beginning.
Like in the beginning, you went through the methods. Like how?
Yeah.
How can I don't know. I don't have an answer. But if we can do a second take, which gives the press release what the study wanted to do and enrolled 140,000 patients, and it was negative, like something like that. Not an academic presentation, but a Dr. Oz presentation.
A Dr. Oz. Okay.
Other than that was fun.
That's fun.
Yeah.
It was nice that we had a little bit of that. You're right that the controversy makes it a little better. Like
we actually agreed, but it was fine to put it in a way that we were disagreeing.
That we are disagreeing. I know you're like a little more pro. I'm a little more con, like clearly con, but yeah, you're right. Okay. I'm kind of like a really big hater. Like I get really annoyed that people can just like go off the streets and buy it. Like, I just think there's no other field where like people can just like, you can't go off the street and like order a pilot, like you can't fly a plane. Like, how come people can just practice medicine without, I don't know.
On their own.
Anyways.
We don't need doctors. We can do this. I mean, of lesser of two evils. I'm like, between that whole body MRI or whatever, I'll take this one over that one, but still.
Yeah.
Problematic.
It's still just capitalism. Anyways. Okay.
We're here to talk about the NHS-Galleri Trial. This was a clinical trial performed in England, and the purpose of which was to use a novel blood-based test to determine whether or not cancer could be caught early. They looked at 140,000 participants without symptoms between the ages of 50 and 77. They took blood tests 1 year apart for a total of 3 times. And the purpose was to use a novel type of technology that's been in use in the oncology field for a number of years. The premise being that tumors will shed DNA, the genetic code of life, into the bloodstream and be detectable. And so the purpose of the study was to determine, especially if they could find later stages cancers earlier and thus lead to cures.